Here.
Dr. Terrell,
Here.
Chief Forsyth,
Here.
Ms. McDonald, Mr. Babbage, Mr. Brandolino, Mr. Cicero, Mr. Gould, Dr. Carsavage, Dr. Fitzless, Dr. Soderquist, Mr. Vega. We have a quorum.
All right. Pledge allegiance to the flag.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, the only comments that I have is to thank board members present for attending today, although I think it's probably cooler in here and more comfortable than out there working in the yard or wherever we were planning to do. So thank you for your attendance. Okay, we'll move on to old business, and Sue, take it from here.
I don't have any old business.
No old business. We'll move on to new business, and first item is family case management program elimination, excluding APOR's medical DCFS case.
Okay, if you recall, back in May, we had a layoff and bumping situation whereby we laid off 22 employees in family case management. We had 20 union staff and 2 managers. And at the time, it was a layoff status until we had time to further take a look at the situation, take a look at the state programming, state funding moving forward, et cetera. And at this time, we are looking to permanently lay off those 22 staff. So the family case management program, as it were, will not be returning. We will continue to do the high-risk family case management, the APORs, the DCFS, Medicaid case management, and of course the BBO, which is a high risk but a separate program. Did I get all that, Pat?
You got it.
Okay, thank you. So the fact that the board took formal action to lay those individuals off, to lay that program off, we thought it'd be the right thing to come back to the board and have a formal action here as well. Now, we don't do this by resolution. However, we are asking for a motion for the executive committee to agree to those permanent layoffs.
Right. And anything that this committee does will go back to the full board for the board's approval. So it will be a recommendation from this committee to the board to take the recommended action. I think before we move on to a motion there and any further discussion, could you just give us an overview? I mean, we've all heard that the state has a 6-month budget, and what that means for funding, what we've seen with respect to additional dollars or any information like that.
Sure. Unfortunately, I don't have a lot. We stay, very close to our program staff. We stay very close to our trade organizations, and from what we're hearing, we can expect to hear what we're going to get in sometime in August. So in other words, we really can't expect any dollars until maybe mid to late August. I don't know how quickly that will happen. The thing about it is the program staff, whether it's at IDPH or DHS, no matter where they're at, they are, they're in with the program. They review our programs. They're our go-to people for, program questions, initiatives, et cetera. They're not really connected to the funding. So we ask them and they don't know. That's a separate, that's a whole separate thing to them. They're not in any control over who gets paid or when we get paid. So that's something that we don't have any more information on. Now, I was at Comptroller Munger's website over the last couple of days, and from what I see there, it's a pretty terrible picture. Chief, you were good enough to send me a link there, and I did look, and I've been looking since. And as of Monday, late Monday, I believe the number or the dollar amount that the state doesn't have to pay these bills, how much it's going to put them behind, is 8.1 billion. That's with a B. So they're going to be paying bills, but they're gonna be running at a deficit. So, you know, that doesn't bid well for us for this next fiscal year. They claim that, she claims that by the end of our calendar year, December, it's going to be over 10 billion. So, again, not bidding very well for next year. In addition to that, there's about 60,000 unpaid bills at this time that they're reviewing, they're triaging, for lack of a better term. But, you know, they're not necessarily first in, first out. They're looking at, you know, the size of the program, when was the last time we were paid, et cetera. So that's what I know as far as the financial situation. Now with us, we've not received anything other than maybe about $100,000 in our tobacco program. Is that correct, Denise, right? About 100,000. We've received what we've billed, so that's good news. But that's it. It's not like the stopgap budget was approved and all of a sudden we started getting flood money. I don't think we're going to see that. In addition, we're hearing some percentages, 50%, 65%. We may be only paid that percentage instead of our 100% of what we agreed to initially. So that's not good information. That's not good
I
news.
have a
either.
question for Keith. One of the issues that came up when we discussed legal action against the state to recover money contractually, you know, entered into, it said that if there was no appropriation, then they were not obligated to pay us. Well, if there is appropriation now to pay, can we then enter into some kind of a legal action against them for recovery of money that we spent in good faith based on their contract?
So like the other 35% of the
Yeah,
50%?
really. Yeah, if they come back and say we need 65, well, I'm sorry, we've got a contract here that says you're gonna pay us 100%.
I can only assume, and I'm not sure that that's, I don't know the answer, but I believe that what they would have done was probably make the appropriation generally without specifics to which programs and to which whatever, and unless that appropriation specifically funds certain programs, that then they are still out by that clause in each contract that says unless your appropriation is approved. So they very most of the time they've got that back door, and it's pretty hard, I think, to be able to defeat that. So I don't think by virtue of the fact that they passed this 6-month budget that you can look at that appropriation and say because of that, then you're violating the contract because now the appropriation has been approved. Because I don't think that it specifically speaks to which one, as Sue was saying, which one it basically was used to be funded. They're now going through that process, and if they come back and say these appropriations are specifically for these programs, and then they fail to, within a reasonable time, fund those programs, then I think obviously we have a better argument. Suing the state is really a bad idea. It seldom comes out well, and
Well, I'll tell you a worse idea, trusting them.
well,
That's a worse idea.
absolutely. and
Cheat
I-
me once, shame on you. Cheat me twice, shame on me, and I'm.
And I think that's the lesson that they're trying, that everybody is learning as a result of this experience is, in all of the contracts that we have, all of those things need the same provision in there that we have no obligation to go forward with any of our contracts. And we've tried to, at least any ones that have come through our office, I think, make sure that we added some provision that'll let out, with an out, so that we could be out as well if we don't receive the appropriations as promised by the state. And that's the domino effect. It basically, they avoid their obligation. We then have we don't have an option but to do the same with ours.
Okay, that was hopeful.
Yeah, well, if we started an action now in a couple of years, by the time it got resolved and by the time that we had spent
Yeah.
considerable money, the only way that those things are usually successful is if you get the whole gaggle of everybody who is in like the same or similar circumstances. They all get together, public fund the thing, so that way one entity winds up taking on as a test case and basically.
And I know that there is a lawsuit that has been filed by social service providers, and that's working its way through the system.
And I think that was for child care, or I believe that was for child care for DCFS and
Right,
for
specifically for that.
Okay,
them,
so
and
that's not.
their need is different, and so therefore they have urgencies and so
Right.
forth that they can allege, so.
All right, thank you. Pat, would you like to comment on the recommendation here? I presume you may have some input into it.
Well, yes, you know, when the new family case management grant came out, we had to actually write for the grant. And the part of the grant we wrote for was just the APORS and the DCFS medical case management, because that's the direction that their state was going in anyway. This is not, I don't think there's anything to it. Did I?
Oh, it's for.
It's blinking battery.
Oh.
Okay.
Okay.
Okay, I'm gonna just talk loud. How about that? How about if I just like
Yeah.
raise it up here? If I hold it? Okay. Okay, can everybody hear me now? Okay, the direction of general family case management was, it was going in the direction the last 3 years to be just high-risk family case management. But what happened last year is that everybody in charge at DHS left. Dan Harris left, Glendine Burton left, everybody left. So there was no direction. They have an acting director. They had hired a contractual person who has since left. So they've never quite made the decision to go just high risk. Now I was told this year that next year when the grant comes out, it's only going to be a high risk grant at that point. And that they're putting more of the emphasis on the Better Birth Outcomes program for the high risk moms, and then you've got your APORS for your high risk infants. So we really are following what they were going to do anyway. There are other agencies in the state that also went just high risk nursing.
Have we heard anything back from the grant that we wrote? You said that they were
We've received the grant, and it's accepted.
for the next fiscal.
For FY17, yes,
Okay.
we received it.
Okay.
And we actually have 4 high-risk nurses that are working just in APORS, DCFS, medical case management, and the Better Birth Outcomes program, which was a separate grant. Better Birth Outcomes is a separate grant, which has since, for this next year, it's now 57% federally funded. That they're trying to get that to be a more secure grant, so that's the future of family case management is Better Birth Outcomes and then the high risk infants.
But we're still back to a issue that the state may choose not to pay us what they've contractually agreed to.
They've paid us a certain amount through the pass-through money. That was, I don't know off the top of my head, we were supposed to get 77%. I don't believe we did. We got 60-some percent. I don't know, I know Better Birth Outcomes will be paid. According to what they've told us, Better Birth Outcomes will be paid. But I don't know about the rest of the family case management money of what from last year.
Right now, we're at about 65%. As of the end of June, we're at about 65% of, for dollars for case management. But
They were
that's-
supposed to
Yeah.
guarantee us 77%.
So that, I mean, we may be at 65%, but I don't think we're gonna end up at 100% at the end of the
At
fiscal year.
100%. I was down about that.
Okay, that's another issue. Okay, I will entertain a motion to approve the family case management program elimination that excludes APORN and medical DCFS case management as a recommendation back to the full board.
Second.
Second. Any further discussion? All those in favor of the motion indicate by saying aye.
Aye.
Opposed, motion carries. Okay. You want to go through?
Yeah, I think I'll kind of go through the packet that you received first. My apologies for all of the paper, but there's really no other way to do this. There's a lot of information to share. There's a lot of numbers to crunch, there's just, a whole lot to think about here. And the best way to do that was to get, most of that to you prior to the meeting, so you had some time to read it, digest it, maybe formulate some questions. I'll go through the packet and explain why certain things were in there. And then today you have at your desk there some additional documents that will serve as part of our discussion as well. So if we can just go through the packet. I included this document here, which is just really an illustration of where we are in staffing. This is a document that our HR department updates continually. And right now, after the layoffs that occurred in May and some subsequent months here, at the end of, I think this came out at the end of middle of July. This was just last week. We are now down to 288 employees. In 2008, when we were going through that whole Kronos initiative and going online with the automated timekeeping system, we were at about 376 employees. We were close to 400, and I know that because we were talking at that time about, gee, how many licenses should we purchase, and we purchased 400. So we were at 375, and we are now down to 288. So that is the illustration, and you can see where the staffing is. These.
I have a comment.
Sure.
EBO, we have 4 environmental health, we have 1 behavioral health, and we have 1 family health services. Pat and Joe, I'd like some comments on, we have an office with 6 people.
We actually have EBO, there's 2 people, 3 days, right now it's 2 people, 2 days a week, based on caseload. When we had to make the cuts with family case management, there's only so many WIC certifying health professionals, so we have to go where the people are. So right now, until their caseload gets built up more, we have 2 staff, 2 days a week out there. And then we also have immunizations that goes out once a month, but soon to be twice a month out there.
Joe, you're...
Yeah. We've had a reduction in staff in the past year. We also have a psychiatric shortage. If I could, I would be putting a psychiatrist out there for hours. There's definitely a need. SAS operates out of there, and we have some limited outpatient adult. And I'm not able to put any child and adolescent because I've got slots open, and we've done some reductions there. We've also dramatically reduced, we lost our clinical supervisors, and we've dramatically lost a number of graduate students, including doctorate students, that would have been going out there. And again, this is all in the last 9 months with the reduction in force.
Well, I know that we just entered into that lease, a year ago?
Yeah, it was
For
a year like
EBO,
April.
and things have certainly changed, and I think at the time, if we thought we were going to have so few people there, we may have reconsidered the size of the operation and
The amount of space we need.
whether we needed it. I would ask you to take a look at the lease and see what it has with respect to a clause that might let us reduce the space or just walk away from the lease. The state seems to have no trouble walking away from things.
Well, I know the answer to that because we were very careful when we wrote that lease. And we have an appropriations clause in there. We put a clause stating that if there was no appropriation for the lease payments, that we would not be held liable for that. So now, how they might negotiate with us to maybe go from 3 units or 4 units, I think we have 3 units, down to 2 maybe, and maybe just revamp some of the space. I mean, that's a possibility.
Now, the other thing, I would take a look at that, please.
Yeah.
And then, if we can't get out of it or can't reduce it, then maybe we can contact through the county executive's office and see if there is any interest on the part of other county departments in locating in that office and sharing
the space.
some space and offsetting some of our expenses, so we'll
I'll
take a
do
look
that.
at those two things.
Sure.
But the big question on that, though, is that East Branch office really needed? That's kind of where you're driving at.
Yes. Yeah. If we're locked into a lease that we can't get out of, then a second option might be to find someone to share the space with us and take some of the expenses.
But the question is how much activity is rolling through there when you're talking about people only working 2 days out of the week or hours out of the days or whatever. Is it really, for the expense that we have in there, is it really that much?
Yeah, I think
to
that
have it?
we would all probably agree at this point that it's underutilized because of what Joe has mentioned and Pat has stated. Certainly, we didn't think this was going to
Sure.
happen when we entered into it, or we wouldn't have done it.
Right.
The place we were was about,
Yeah, well, I remember that. I was here for all that, and I'm glad we moved, but, you know, now we're looking at something, again, where we have to cut back on things, and instead of always going right at the people that work for us, you know, we're spending a lot of money just for the rent of this place and
Right.
keeping it up and stuff. I mean, there's money there to be saved,
Yeah.
and we have to really look and see if it's worth saving that whole branch.
I know that, you know, environmental health staff are the only staff that are out there full-time.
Full-time.
Four, excuse me, 4 individuals, you know, they're out there every day because that's their territory. So bringing those individuals either back here or perhaps finding another office. I remember when our East Branch sanitarians were in a bank. Remember that?
I negotiated that lease for that bank.
You know,
They tore
so,
that building down too, by the way.
so, but certainly we will look at the whole process here. Yes.
One of the reasons why we are only there 2 days a week right now is that when we lost the family case management piece, our WIC appointments went from being an hour to a half hour. You can fit twice as many appointments in a day. So utilization of the staff is that they only need to be there to see the same amount of clients that they used to see. They only need to be there 2 days. We are hoping they'll build their caseload up more in order to be out there a third day. I would love them to be out there a third day. But there's not enough work to do 5 days a week out there where we could use them here seeing people. So that's why
And
ours changed.
I appreciate that you run your division that way to, you know, to use them to the best of their ability. So is there a need from the public to have that office out there?
I think I mean, it's a long drive here for the WIC program. It's a long drive for people that have trouble getting rides, places, and transportation to go from University Park all the way to here, in my opinion. But I don't, you know, you'd have to look at numbers and utilization of all the programs.
There's a loss, if you close that office and brought everybody back here, there is a loss of productivity, especially in environmental health, because they need to now incur a half hour out, a half hour back of lost time just to get to the area they have to work. I think maybe it's an issue of right-sizing the office versus eliminating it. In other words, we have 4 people and have office space for 4 people, 6 people, as opposed to 20 people, whatever the capacity is there. But I think it begs further.
And I think I hear them both saying, including Dr. Troiani, the services are needed. In fact, they need more people. He's saying he actually needs a psychiatrist out there. So you desperately need to be there, but the space may be something we can work with.
Okay.
Environmental, we do have customers come through on a daily basis. I mean, we could track and find out how many of them, between septic permits and temporary permits and well permits and bringing water samples. We do have customers every day coming.
And we run SAS out of there, and think of being deployed from here out in that area for SAS. I mean, just the mileage would be off the record.
Well, I mean, and this is great to learn this because, should help us as board members to make a decision on which way we're gonna go. Because I really don't know how busy, but it sounds busy, and to me now,
yeah, we need this out there, so we need to figure out how to lower our costs out
That's
there.
it.
Yeah, I
Exactly.
think that's.
And
key.
reaching out to the county, that sounds like a good way to go at the beginning, or finding someplace else. You know. I got a big room upstairs.
Okay, anything else?
I live out there, and it really, if you look at the shape of the county, you really need something out there, you know, unless you just want it always just be Joliet. Just a
Well,
little added thought.
I think we made the determination years ago that, you know, a presence out there is necessary, it's needed, it's welcomed, but I think we need to find a better, more efficient way to do it,
Right.
less costly way to do it. Okay, the other item that you'll see, the rest of these few items are really updates to your strategic program analysis. That was the document, that comprehensive document we talked about, you know, last year. Basically, what we've done is we've updated this document so that the programs that we are no longer doing from the layoffs and the eliminations last year they're off of this. In other words, behavioral health, forensics is gone, addictions is gone. We're no longer doing the YES program, so that's gone. In family health services, HFI, healthy childcare, doula, those are off. So we've updated this actual document. The categories are all the same. The way we've categorized them are all the same. We've just updated it for your information. Now, at some point, we will ask all of the Board of Health members to return your SPAs, and we'll fully update it for you, but for our conversations, we wanted to make sure that you have this.
I have a question.
Yes.
Something. Correctional mental health, that's the mental health that we're providing at the adult
Yeah,
facility?
River Valley
River
Detention
Valley.
Center and the adult detention facility.
Okay, and we are billing the county for direct cost?
All of our costs. It's 100%.
Direct, all of our direct costs?
All of our direct costs.
We're not applying any of the indirect costs, the 800,000 that we pay for lights and snow removal
No.
and all of that?
No. Because their staff is on site. The staff is on site.
I understand that, but these are costs that the county is
Correct.
having us pay out of our budget.
Yeah.
And even if it's $50,
Yeah.
I would say, and Denise, that's another thing for Denise to look at, she's hiding behind.
We see you back there.
You know, I think that at a time when we're desperately looking for money, for us to charge them for direct cost and ignore the significant indirect costs, because we've got to supervise those people. We've got to provide mileage, we're getting mileage.
Yeah,
not
and the
getting that.
supervisors in there too.
Yeah, and just the cost of maintaining and paying a phone bill, paying an electric bill, paying all of that, whatever it is, like I said, if it's $50, I think we should identify it and capture it. Let the county pay our true cost, because they're getting a deal.
And
They're not getting, if they're not paying the indirect, they're getting a wholesale price, so, okay.
And we don't have a contract with them yet, so certainly we can put that in.
If they want us to pay it, they can pay their part of it.
Okay. The next few documents look pretty similar. They're all organizational charts, and they're updated because of the many changes within the organization. So you should have one for or for the whole agency. You should have one for emergency preparedness, environmental health, behavioral health, the community health center, and family health services. Every division was affected. Every division has an updated org chart. So that was in there as well.
I have another question. On the medical records in Community Health Center, I know we've been shifting to the electronic medical records. Medical records staff, what's your outlook for that going forward?
We're down to 3 people, which is to cover all the 6 days. And there's somewhat more of a demand now for medical records from the insurance companies, because they're doing monthly audits and asking for
All the managed care.
the managed
That's what
care.
managed care does. They try to beat you out of a legitimate cost that you are looking to recover. That's what they do, yeah?
One medical records person is down in dental now, assisting down there. Her position is now down there. And then I believe we had a retirement, was it a retirement? And we didn't fill that position, so we now have the 3 in medical records.
So the electronic medical records, which are touted as the end-all for everything, becomes a duplicative system that you've got to have parallel systems running for a while at least.
I would say we don't have a parallel system, but even though we have a paperless record, the environment that we work in the world isn't paperless. So there's incoming paper documents perpetually, and when we react to those documents and put orders on them, and the nurses then carry out the orders, and they have to be scanned into the record. And then there's paper requests, many requests coming from legal entities, the coroner's office, attorneys. So there's these papers that come into our environment that then have to be loaded into the EMR. So we never see a paper record, ever. We do all of our work on the electronic system, but it's the papers that come into our system from externally, even from other electronic environments.
So going forward, we probably would always need a
You always need a
staff.
staff, a minimal staff for the staff. It's not like you have 8 anymore, it's down to 3. And you always need a staging area or a medical records library or room. And it's not something that, it's counterintuitive, really. So you do need the staging area or a provision of a room for them to work in, and you need a staff to respond to all the paper that comes into the electronic world.
And then you need someplace to store all of the
We need some sort
units.
while they're categorizing and getting rid of the last of the paper record. The paper record is held for children to maturity plus 2 years, so that's 20, and then 7 years for adults. And so there's a point at which there's this purging process that happens. But realistically, when you put it in an electronic system, it takes you about 5 to 7, sometimes 10 years to completely purge your environment of paper.
Okay.
And they would be assisting with that purging, the
Yes.
medical record staff.
Purging, scanning, reacting to documents coming in.
Are we storing all of the old records on site, or does some of that go to the county building up on Poplar Street? You know,
I think it's all on site.
it's all on site.
We technically don't need all the space that we have for medical records, except for the basement storage. So if we needed to find more space, we could make that room small.
Okay, so it's not growing.
No.
Okay.
But there are agencies that will come, because our office used them, they will scan old records into the computer, and then they will shred the papers, so you get rid of, because we had that same problem with a lot of boxes and boxes, and then if an insurance company wanted a report from something 5 years ago, everybody had to climb all over these boxes and look. And if for not really a lot of money, they came, we told them what we wanted scanned, they scanned it, took the rest out, shredded it, and then now, if they want something from 1976, it's in the computer and you got it. That's something you might want to look at.
There are options for downsizing. A lot of companies are using, because of the length of time you actually have to keep the paper record, there are people that are using cave storage, but you have to look at the storage cost. There's a retrieval cost, there's a maintenance cost, and then once the record gets so old, certainly you can scan and shred. Depending on the amount of records, I mean, we might have 20,000 records, and to touch that number of records with, if you average 100 or 150 sheets of paper, every piece of paper, every record will cost you. So if we did a cost analysis to see, it might cost it might be cheaper to keep the record for 2 more years and then shred the whole thing, or, so certainly.
That's kind of an ongoing thing.
Yeah.
As they get so old, you
You can purge and
purge them.
shred.
That's why the room's getting bigger.
It's getting bigger, it's getting more space. So there's options if we wanted to do it quickly, as Mary was saying, to make space for staff or other staff or health department staff or what have you. There's certainly options.
Okay. Just curious. Thank you.
Okay. There are a couple of documents that look like this. They are just, again, updates of the listing of programs within behavioral health and family health services. We made changes and updated that information as well. And you will also see a couple of strategic program analysis in your packet. We have one now for teen pregnancy prevention and one for the chronic disease and school health program. Those two programs were not running when we did our initial strategic program analysis. Of course, we don't have the fiscal piece in here yet. That will come later, but we wanted to at least get a description to you of, the program, the target population, et cetera. So you have some idea of what that is involved in there. Okay, also included in the packet was some question and answers that were provided by Dr. Troiani and Mary Maragos. We thought that perhaps it would be useful to you if you just were able to read through some of these questions, formulate some of your own questions, and have those answers. And certainly, any of the questions you have today, we will answer those. If we don't have the answer today, we will get that answer for you. But I thought it would at least kind of spur some conversation and provide you with some information that you might already be thinking. Also in your packet, would be on your desk, is a memo document along with a spreadsheet that talks about our infrastructure costs. When I was doing the budget, and actually it kind of started when we were getting to this whole budget impasse situation, I started looking at the health department's budget and comparing some things to other departments' budgets within the agency. At the beginning of every fiscal year, we get an actual county budget document. It's about 2.5 inches thick. So I pulled mine out and I started looking at it, and I was just trying to look at some comparisons as to what are some of the costs that our agency pays for as opposed to some of the costs that other agencies within the county pay for. And so I put this little spreadsheet together, and as you can see from it, it's pretty glaring that, the health department pays for its own rent, gas, electric, water, sewer, snow removal, security, housekeeping, garbage, groundskeeping, and phone. Now that's not even all infrastructure costs, but those are just the ones that I captured that obviously are, are you guys missing something? No, they're in there, okay.
I just
Gotta find it, okay. I know, lots of paper, I'm sorry.
Yeah,
Stephanie held it up for us.
This is what.
Yeah, I did see that.
Anyway, that's mine now.
Okay.
Maybe in the future it would be helpful if you put up a screen and you had a projector, you could put that thing on a thing, you could all look at it at the same time.
We tried that last time, it doesn't work very well. Our resolution on the projector isn't very, it just doesn't work very
Well,
well.
we need to get a new projector.
We don't have any money to get a new projector. And then we have to change the configuration of the room, and this is actually easier. So my thinking was, okay, so we pay all of these infrastructure costs. So do other similarly situated departments within the county pay those costs as well? And as you can see from the spreadsheet here, the answer is no. Now, I brought this up at our budget conference. Elizabeth and I met with Rashawn Howard, who is the budget director at the county, and we did our typical budget conference where we presented it, and I have that information for you a little bit later. But I brought this up at our meeting. And I said, you know, if you look at all of the costs, all these infrastructure costs that the health department is paying, it's coming right out of our budget. Projected for next year, fiscal 2017, it's $819,500. That's a lot of money. And so my question to her was, could you please take a look at this? And, you know, I'm not sure if I captured all of the right similarly situated departments, because I'm not sure why we pay for some and they don't pay for theirs, and so I don't know what the rationale is. But in any event, I asked them to look at this, and I want an answer as to, could the county assist us in paying for some of these infrastructure costs, like the county pays for these other agencies, these other departments? So she asked me, I had showed her the spreadsheet, she asked me to put a memo together, send her the memo together, I'm sorry, send her the memo and the spreadsheet together, and so I did that. The other person at the meeting was Melissa Johansson, who's from County Board. And she said, well, Sue, you know, what's the difference if we, you know, pay the $819,500 for this, or we give you more in your levy? And I said, nothing. Do either one of them. That's okay with me. So I don't know where it's going to go. I don't know if this is a possibility, but again, I feel like I have to explore all options.
Sure.
And you have to be creative, and you have to kind of dig sometimes to you know, to try to find some answers. So that's what this is.
Does the nursing home have its own phone system, or do they
Yes,
use? They do.
we separated.
We separate.
At one
Okay.
time,
At
we
one time, I
shared.
know we shared.
Yeah, that just happened this past year. We were sharing the Avaya phone system. It's a brand new system. We both have new systems, but now they are separated.
What is rent for us?
$264,000 a year.
Well, what are we renting?
Rent is EBO and NBO, and a portion of, we have a storage site, Cherry Creek, over to the dental.
That's where the bus is?
Yeah, the bus, yeah. And I think that's it, yeah.
Okay.
What about security? Why do we have to pay for security?
Exactly.
It's
I
kind
don't
of a
know.
tradition.
I get
We've
it.
always paid for it. These costs have always been
No,
laid
I
back to
know.
us. And
We're a county agency.
Well, not only that, but, you know, let's look at economy of scale. If the county would go out for bid on garbage for all of the sites, it might be cheaper in the long run for everybody. The same thing with a landscaper, the same thing with security, the same thing with housekeeping. If
snow
we-
removal, everything. There's
Yeah, if we try to
multiple things here
centralize,
that
yeah.
get more
So
efficiency.
that hopefully will be explored. But I put it out there, and I hope that they consider that.
And I'm saving you tremendously.
Well, that's what
Yeah.
I mean, they're not gonna pick up the rent for you, but they would pick up just the items that Sue mentioned
And I
there.
think you're right, it's been tradition, and as long as you don't say anything, they're not going to offer up.
No,
It's
and,
just not gonna happen.
and they didn't have an explanation either, the people I was speaking with. Of course, one's, you know, she's only been with the county for a little over a year, but they didn't have any rhyme or reason as to why it was the way it is either. So, again, just for consideration. Okay, the last, let's see, let's continue to go through this. You'll also see a couple of items that you've already seen, but we'll talk about those later. One is the fees and reimbursements and grants and contracts. That should, you know, look, you've seen that before. We have a budget for 2017 at your desk. We'll talk about that. But the last thing I want to talk about in your packet is this PowerPoint presentation. Now, all of you have a copy of it, and I'm going to go through it because I think it will be good practice for us to do that. I think it requires some discussion. Okay, so I included the executive committee vision statement, and this is really what I think we need to do. This is why we're here today. And it's to position the agency as an outcome-driven, goal-oriented, financially sustainable department adhering to its mission. very broad, but it's what we are here to do. Our goals, the executive committee goals, are first to discuss and consider direction for fiscal 2016 budget mitigation. We will still have some budget reductions that we will need to do before the end of the year. We also need to talk about how we propose to balance the budget for 2017. And in all honesty, I think those two things really go hand in hand. I don't think you're going to do one thing to mitigate this year's budget and then pull that back and do something entirely different to balance next year's budget. I think to some extent, it's going to go hand in hand. And then lastly, and really encompassing all of this, I think we need to determine the future direction of the agency based on community need and our mission, not just funding. I have to be honest, since I've been doing the budget and working in administrative services, I feel like we've been living paycheck to paycheck. And I don't think that's good for anybody, an individual or an agency. And that's how I feel we're living, we're working. And that's getting more and more difficult, if not impossible. So I think we need to make some pretty big decisions here on how the agency will look in the very near future, keeping in mind our mission, our core programs, and our funding. Just a reminder of what our mission statement is at the health department. It's to prevent disease and promote a healthier environment for all. To that end, agency professionals assure the maintenance of flexible program initiatives and develop sound public health policies based on a thorough assessment of needs. Now, the Community Health Center, at their governing council meeting every month, somebody reads the mission statement. But I don't know when the last time is that any of you had the opportunity to remember what it was and to hear it. So I thought it important to include that. Okay, let's talk a little bit about what public health actually is. And certainly our agency as a whole, we do two things. We do public health and we do healthcare. But there is a difference. And so I provided some definitions there for you. And really public health is the science and practice of protecting and improving the health of a community through prevention, health education, control of communicable disease, application of sanitary measures, and monitoring of environmental hazards. Health care is the preservation of mental or physical health by preventing or treating illness through the services provided by a health profession. And those were taken out of the dictionary. So certainly public health is more a community, a broad approach, and healthcare is kind of specific to an individual or sometimes a population. Then I included a slide on what our public health system looks like in Will County. And this was taken right out of our MAP collaborative, which is a very active, very successful collaborative that we head up here at the health department. And if you look at it, the public health system itself is very complex, and it does include, providers, medical providers, and mental health providers, but it also includes other social service agencies and other agencies within the county structure. It also includes universities that I don't think that we probably get enough from and derive enough benefit from. I think that universities provide us, there's so many resources there that I think we still need to tap into. So this is just an example of what our whole public health system looks like. On the next slide is what the role of local health departments, what the role is. We have three core functions. And those core functions are assessment, assessment, policy development, and assurance. That's what we're required to do as a local health department. If you look at your desk, you were also given a handout. If I can find it, I got too many papers. You have it? Yeah. Thanks.
I have an extra one.
Thanks. You got mine, no. If you'll see a handout like this, and what this is really the three core functions, assessment, policy development, and assurance, those are all around what are called the 10 essential services of public health. Public health is supposed to monitor health, diagnose and investigate, inform, educate, and empower, mobilize community partners, develop policies, enforce laws, link or provide care, assure competent workforce, and evaluate. Those are the 10 essential functions that we're supposed to be performing. As you can see from the graphic, nowhere in that does it say that we have to do everything, that we have to be everything for everybody. We have to provide assurance, we have to develop policies, and have some source of, some type of assessment process, but we don't have to be the end-all be-all for everybody. And certainly with the fiscal situation as it is, we can't. The next slide is a kind of a recap of the recent trend that we've been experiencing here at the health department. We've been downsizing due to budgetary constraints 6 times, well actually 5 times in the last 6 years, and no doubt we'll probably have one more round before the end of the fiscal year. 6 times in 6 years. Most for-profits would never survive this. They'd be closed after number 2. I've done a lot of research on downsizing. I've done a lot of reading on how it affects agencies, how it affects people, because people are our agency. And there's some really negative effects to downsizing. Low morale, low productivity, training setbacks, difficulty in staff retention, difficulty in staff recruitment, and increased costs. And I can tell you that we've experienced all of these. And we will continue to experience all of these until we straighten some things out. None of it's good. And don't get me wrong, we're all doing the best we can. We're all working hard, we're all trying to be efficient, we're all trying to cut costs, we're all working more hours than we're required, but it is the way it is. So we're trying to get off this train. So we have some options, and the rest of today is going to be talking about some of those options, but obviously we are going to need to look at cutting programming. And I think we need to look to our strategic program analysis. That's a very good, a very comprehensive document to lead us. I would ask that the Board of Health make a formal request to the county board to increase our levy. They can't say yes if we don't ask them. They can't say no if we don't ask them. I think we need to put it out there. There's a way to do that in informational, respectful ways. They say no, and then we can move on. But I think that the county recognizes that there are increased costs for everybody, including our agency. And if you don't ask, you don't get. So I'd ask the board to consider.
I think you should prepare that for the August meeting.
Okay, I'm glad to do that.
And it should have some historical information on how the levy has not grown over the years and how our costs of labor have grown and our other costs. And then how we've coped with that is by doing layoffs and cutting expenses. And going forward, that's the only way we can meet the increased demand for money, by eliminating programs. Can't do that indefinitely.
Okay, I will do that. So the overall goal is to decrease costs and programming to a level well supported by our budget with long-term sustainability. We cannot continue to cut positions and programs on a continual basis. The next slide here is, I needed to lighten it up here a little bit.
I thought that
Or
one.
put it down.
The next slide, it says, it is better to do less well than to do more not well. And the graphic here, for those of you who may not have it, is a guy at his desk, and he's at a computer, and this paper's just flying out of the computer. I'm sorry, but that's how we feel.
Yeah.
I don't think any of my leadership or my managers in this room, is there any of you that don't feel like that on a regular basis? No, that's how it is. So we need to regroup, we need to reorganize things a bit, and we want to do what we do well. We don't just want to do a bunch of stuff. We want to do what we do well. You know, one of the things I was always proud of this department for is we have a lot of model programs over the years. And we still have them, but we need to be able to continue to do that. And I just feel like so many times we're in crisis management all the time, and we don't have the opportunity to always put our best foot forward. We have to be able to do that again, and that's where we need to go. So I have a direction that I'd like you to consider, and of course the entire board, and they've gotten this packet too, so between now and the August board meeting, they've got plenty of time to look at this stuff. I'd like us to look at being a community health-based agency. And what that means is, you know, community health is a field of public health. It is public health, and it's concerned with the study and improvement of the health in a geographical area. That could be a town, it could be a county, it could be a city. You know, if you just Google community health, there's a lot of information, there's a lot of resources. CDC even actually has a whole section, a whole area of their website and their resources on community health. And I think that's kind of the direction we need to go. Some of you might have heard the term population health. That's kind of thrown around as well. Population health is different than community health. Population health is typically something that is in the medical community, that they're kind of targeting a population to look at and improve outcomes for. Could be the diabetic community, it could be males between the ages of 18 and 24, it could be HIV, STD, whatever. They're looking at kind of a specific population and trying to improve that population's health. Community health would be us trying to improve the overall health of the county of Will, which really aligns very well with their mission. There are 3 components to community health. One is health promotion. That's the educational and social efforts that you put out there. It's the outreach in the community. It's the education to the community at all different kinds of levels. There's health protection, and that's implementing laws and policies and certain legislation that comes about to protect the public's health. And then lastly, it is actually providing some health services. Could be immunizations, that's a good example. It could be, what else? Could be some HIV clinics, that sort of thing. But it's actual health services that you provide. And then there are some actual tools that a community health system utilizes. And that's epidemiology, it's community organizing, health promotion and education, disease prevention, management, evaluation, and assessment. Those, again, align pretty well with this. And if you look at the next page, we're already doing a lot of this. Administrative services, we're the management piece, the evaluation, and part of the assessment piece. Environmental health, certainly the health protection, family health services, the health promotion, the education, the epidemiology, the evaluation, the community organizing, and community health center, of course, they provide health services. The other piece that we're already doing that is just, it just kind of smacks you in the face is our MAP collaborative. So much of what MAP does pulls right into what we should be doing, I think, more as an agency. You know, I asked Jenny yesterday, I said, how many people in the health department, how many staff in the health department regularly participate in MAP to some extent? Guess how many?
100%.
No, I wish. We don't have time for 20. Now, it may not seem like a lot, but there's 20 of our staff who regularly participate in MAP. We're talking about regular meetings, action meetings. This morning, we had an executive committee meeting. Joe was there, Scott was there, Pat was there, I was there, Jenny was there. I mean, and typically Mary's there as well. You had a conflict. So we spend a lot of time on MAP. Personally, I think we just kind of need to fold. We need to bring MAP and Will County Health Department more aligned. And it will help our MAP process, and it will help our health department program. That's, I think we need to do. We're halfway there. We just need to bring it together. And so that's where I'm at. And that's the direction I think we need to go. And, you know, certainly this is, you know, this isn't based on performance of any one division. It's not based on personality. It's not based on personal preference. It's not based on anything other than our financial situation. And, you know, years ago, or through the years, this agency looked at the community and decided, okay, what does it need? What should we do? And we answered that call. And we've answered that call in behavioral health for decades. We've answered that call in the community health center for, you know, since what, 1995. But I'm not sure that the needs are the same. Or if the needs are the same, I'm not sure that the resources are the same. And the ability to meet those needs are the same. And so that's why we're here today. Certainly our financial situation is not the same. And to be good stewards of the taxpayers' money and of our levy, we need to make some changes. Any questions about at least what's in your packet so far?
I'm just thinking.
Okay.
This is all discussion.
Sure.
So, going with the community health system, what would that do for us to solve our problems? Because some of the programs we have now just wouldn't fall into the community type thing. So we like rewrite what all our programs are, cut them on down.
Exactly. That would be a start. We, as I mentioned, you know, there are divisions that we already have that do much of the community health piece. We have 2 divisions that are all clinical. Of course, they do some patient education, but really they're clinical, and that's behavioral health and the community health center. And in a community-based health system, community-based public health system, unless you have, you know, oodles of dollars, typically clinical systems, clinical practices are not included in community-based public health. And that's really just, that's the fact of the matter. Now, in order to be able to do some of the, you know, the 10 essential functions, we would have to, if we don't continue with clinical services in either or both of these divisions, we still have to assure that the clients and the patients are getting those services. But we do have some things in place for that already. We have assessment through MAP and being able to connect people and network people that way. We also have the LAN, Local Area Network in Behavioral Health, that is already a network of providers that could assist us in transitioning clients. So, you know, we could still keep a piece of the health services portion, whether it be immunizations or putting on some clinics, but you know, I just will say it, we can't afford to continue to do behavioral health and the community health center.
Unless the county gives us more money.
Yeah, and it would take a lot more money.
Dr. Troy, what's your response to that?
Well, this morning I put together a quick one-page sheet. And let me just, if I can walk you through it real briefly, I'm not going to read it. We've got 3 assumptions. And again, I'm taking a hard, cold look. One assumption, in a best-case scenario, we're going to get half the money they owe us from last year, which means a dramatic shift in financial burden on Will County's health department. Secondly, as we look ahead at the next year, and I agree with Jim, fool me once, shame on you, fool me twice, shame on me. Looking at next year, and we've got reliable sources of information. We have the trade associations, the professional associations, our legislative committees. I've talked to more political people than I care to in the last couple of months. And the outlook for 2017, the best case scenario, I think, from what I'm hearing, is maybe we'll get half the money.
Right.
Okay. Best case scenario. I mean, I would be happy if that happened. But there's also something else that's going on I really need to make you aware of. And we've received recent communications, and that's assumption 3. The state of Illinois is moving from funded programs to fee-for-services. I'll give an example. We have a program, Mental Health Juvenile Justice. Right now, we get 100% funded. MHJJ, they just put out an email and saying, well, what do you think if we make this a Medicaid program? What does that mean? It means we have the program, we get no grant money, and the program pays for itself by Medicaid billing. And I looked at the number of services that we're able to bill and provide for. If that is the case, at best, 15 to 20% of the cost would be reimbursed through fee-for-service, which meant the county, in order to maintain that program, would have to put almost 80% of the funding for tax levy.
So that's not.
It's not sustainable, not sustainable at all. And those are the assumptions that we're going on. Again, out of the grants into complete fee-for-service, what are our considerations? One, and this is brought up to me time and time again, our per unit cost in behavioral health is pretty high. And I would assume also at the FQHC, primarily because of salaries and a very generous benefit package, what I'm very pleased that I have. When you get grants, they talk about 9 to 12% being for benefits. And ours is, I used to figure 42%, is it 38%?
Denise?
It's probably getting a little higher. It's probably in the 40s.
In the 40s. If we apply for a grant and put in that our benefits package is that, I mean, we would get turned away. At the same consideration, our community partners, we're actively engaged with the land. We meet monthly. We've been meeting monthly since June of 1993. They've been able to respond quick to the changes. And how are they doing it? Freezing programs, freezing positions. So their capacity in the last couple of months has shrunk. For example, in our discussions with Trinity Services, they've got 3 outpatient therapist positions, and they're simply freezing them because the state is not reimbursing. They're not getting the money paid. So within the community, on the assurance issue, the capacity has decreased. And consideration 3 is there's a void of clinical services for kids out there. We got our start in the 1950s by being a child guidance center. If our child and adolescent services went away, we'd be hard-pressed to find any providers, which is different on the adult side. And consideration 4, adults with chronic persistent mental illness are facing a shortage of mental health and psychiatric services. Again, these are external forces that are impacting us, Trinity, Cornerstone Services, Grand Prairie. We're all dealing with the same issues. So it's not that the services aren't out there. It would take time to get in place. There are long waiting lists. So for the adult side, it would not be as critical for the child and adolescent side. And I'm laying out 3 options, looking at the whole continuum. Option 1, the Board of Health could simply say, we're not a core function of public health, and make a decision to phase out behavioral health programs. That's one option you have. A second option you have is utilizing the strategic planning process and using what we call a zero-based budgeting approach, financially restructuring the division based on needed priorities. We're not going to be able to do everything for everyone. But what are our needed priorities and what is the available funding? And when I talk about available funding is our county tax levy and what we get in for fee-for-services. I have zero confidence in grants. I mean, my option number 3, I had to put it down there. Maintain current programming, assuming the state of Illinois funding will be restored for state fiscal year 2017, and the health department will be made whole for fiscal year 2016. And I would believe that if I believed in the Tooth Fairy, the Easter Bunny, and Santa Claus. And I'm too old to believe in the Tooth Fairy. Tooth Fairy ain't going to come along and bring us a bunch of money. And I don't believe in the Easter Bunny and Santa Claus. So we know that ain't going to happen. We know that ain't going to happen.
Joe, I have a question.
Yes, sir.
We have 3 hospitals
Yes.
in Will County. And my understanding is they benefit from our services in that when a mentally ill patient is brought in by the police or comes to their emergency room, we come to the hospital or we triage or do something to screen that patient and then help the hospital determine whether the patient is...
What the hospital is able to do is discharge them to the health department.
Okay.
Okay? Which means I'm passing on my liability, I'm passing on my follow-through. You guys are taking care of them, so I can step back. And at the county board meeting, the vice president from President St. Joe's testified that amounts to about 50 patients a month.
Okay.
Yeah.
And
We've reached out to this gentleman twice to request a meeting.
I think that we need to put a value to that. What does it cost us to provide those services? And then whatever the fees for service are, you know, whatever that is, whether there's a grant, whether it's worth anything, and divided by 3, and have the Board of Health pass a resolution asking hospitals to participate in that program to the tune of 1/3 of whatever our costs are, if they want to see that program continue. Just like the courts. We eliminated the forensic programs, what happened? Courts came in, picked them all up, hired 3 of our employees.
Yep. Yeah.
And I think that if the hospitals are benefiting from money that we're spending and don't have anymore, then if they want to keep it, they can pay for it, or at least have the opportunity to say no.
Jim, you bring up a really good point. You know Lexington Brothers Behavioral Health Hospital?
Yeah.
They went ahead and took over Northwest Community Mental Health Center.
Oh, there you go.
So they took it over because now they have the Community Mental Health Center where they can refer their patients.
Because if we're not here for them to call,
They would be devastated.
that patient is theirs, and they need to admit them if they need to admit, and they need to figure out what to do with them.
Correct.
And this is just like the courts.
Yeah.
Health levy money and whatever fees for service we get, we are subsidizing a benefit to those 3 hospitals. And they need to be asked to participate in keeping the program, or they can deal with it. That's my opinion. I think that should come back. I invite others to comment too.
What if you notify the hospitals that you are going to eliminate the program and let them come to you and say, well, we'll help subsidize? Because right now, you're saying it takes a year. So if I call your office and I say I want an appointment, they say, well, this is July 16, we'll get you an appointment in August the 17th. That's the same as not providing any service at all.
Well, Joe and I have had this conversation, and actually Joe has reached out to the gentleman from Presence a couple of times, because we were going to have a meeting. My whole goal was to have a meeting with the individual and let him know what was going on, and ask that they participate in this, because it will end up on their doorstep.
It's going to make a major impact on discharge plan.
Now, from what I understand, the bulk of it is Silver Cross and St. Joe's.
Yeah,
Adventist,
Predominantly St. Joe's.
yeah, Adventist is maybe 10%, maybe,
Yeah,
not
very
even,
low
very
numbers.
small.
We
So-
don't want to exclude anybody, and if it's 10%, it can be 10%. I mean, we want to
Right.
share,
Yeah.
we don't want
Be the
to,
first one to pay.
No, everybody should pay their way, so to
and it
speak.
should include this is our last option. We have no money to keep this going. If you benefit from it, participate, or you're going to deal with the problem.
I wouldn't even give them that option. I would send them a letter saying, as of October 1st or September 1st, we're not able to provide this service, and then let them call you, and then you say, your call is very important to me, I'll get back to you.
There's also one hospital we failed to mention, and that's Madden Mental Health Center.
Okay.
Yeah.
Because the state of Illinois still sends us patients.
Yeah, they'll give you a contract real quickly to say,
Oh, yeah,
no,
yeah.
I won't pay anything,
And
but
then
they'll
I
give you a
get back.
contract.
And, you know, this is the kind of the schism. When I talk to my contract manager, when I talk to my regional director, very nice people, very helpful people, and I'll say things like, by the way, we haven't been paid in 13 months. Oh, total disconnect. They're operating as if we are getting our funding, and they just basically say, I don't know anything about that. In fact, we know more about what's going on than they do, because sometimes they call us and want us to provide them with that information.
Well, I think Joel and Sue should go ahead, I'm sorry. Anna.
No, what I was going to say is that, we talked about this a little bit last time we met, but about the patients. How they've been impacted by the people that have been laid off, the people that are retired. There has to be a better way to do this. St. Joe's is for profit. So it's easier for them to see them and do what they basically have to do to get them stable and refer them out. Are they not agreeing to meet with you, or they just simply just not gotten back?
You haven't responded.
No response whatsoever?
No.
It's been probably 3 weeks,
Okay,
4.
4 weeks.
The hospitals are community organizations, and the hospitals morally and possibly legally need to provide charity care. And they need to cooperate
Only
with
for
the
so
people
long.
in the community.
They keep them for a point, and then once they're basically considered stable, whether it's mental illness or anything else, they let them go. And it's up to the county to take over.
But who says it's up to the county?
Well, it's up to the county because we've been doing it.
Yes.
It's not a typical.
Okay, but you can't afford to do it.
It's not a typical health department function.
Right,
Yeah.
so you cannot afford it.
But, from a statute perspective, mental health care is the primary responsibility of the state of Illinois.
Oh,
Yes.
that's too bad.
You know, the room we're sitting in here was funded in part by Silver Cross Hospital, $100,000. Because I went and asked them, or Dr. Gutierrez and I went and asked them, and they gave us money. You know, well, he's taping.
Save it for executive session.
But no, but if you ask them,
Yeah.
they will, if they see a benefit to it, they will participate. Silver Cross Hospital, at Dr. Gutierrez's request, helped fund the community health center. What was it, $300,000-400,000 they gave over a certain number of years?
Yeah, it was 3.
You know, there is precedent for the hospitals coming in and participating with us in the past.
Services.
But Silver Cross is an independent hospital. Covena's part of a larger organization.
I
that
understand
They have
that.
to go
It
to.
still impacts them.
It's going to impact
A
us.
tremendous impact. And the other part is Silver Cross is more likely to help than St. Joe's.
Oh, yeah.
When we say non-for-profit, they are a business. They will do only what the law requires.
Yeah.
Silver Cross will keep them until something is found. And that's from histories of working with both.
And they may decide, well, if the health department's going to not do it, then we will hire our own people to do it, just like the jail did. And again, we go back to the assurance function. We don't have to do everything. We have to make sure that it is available in the community and encourage that. We don't have to do it. We can't afford to do it. If they say it's very valuable for us to have the health department there, then maybe they'll put some money in it. If they say, there's another way to do this, and we will fund it, because of the reasons Joe mentioned, our cost to provide behavioral is very high. That applies to every division here. Our costs are higher because of the benefit package and the wages. You know, the Trinity isn't paying probably what we pay our mental health counselors.
No.
Well, the other thing to,
I'm sorry, I'm wondering about community involvement. St. James was going to close and just go back and work in Indiana, and there was such community pressure that they revised and they're staying, and Lithier feels a little bit in the Heights, but it was very heavy community pressure. I'm wondering if we're just all talking about this over and over, how much does the community know about it?
well, I will tell you that, you know, we went through this whole, you know, I was at the county board meeting, we went through the whole issue with the loan, and certainly there were some consumers that were at the county board meeting, but I don't know if they would have been there if it weren't for us prodding them to be there or asking them to be there. You don't get much from the community at large, and we're certainly not going to get money from the community at large. But one thing to remember about the hospitals is, you know, the hospitals may be willing to fund the person going out and doing the assessment, but then what? We still can't afford to do the outpatient mental health services here at the agency. You know what I'm saying? I mean,
It's piecemeal, but if you can get somebody else's money to help offset some of our, you know,
That might
being able
be-
to salvage something under a new model that Joe's
Right.
talking about here.
some kind of a,
One of the
work through
things
the
that,
transition period.
one of the things that I tried to do when we were organizing this community health center is reach out to fraternal organizations, Rotary, you remember. And I was able to hook up with a guy who was a higher up in one of the things with Rotary, and he made a commitment that he would try to help us identify Rotarians who would come forward and provide money, provide services, provide goods, whatever we needed in building this thing. And we went to everybody and really pitched what we were doing. And it all came down to, you're a unit of government, and we pay taxes to the unit of government that you are a part of. We don't donate money to units of government. And we finally, I mean, we even hired a staff person, or two people, maybe one left, the other one, and beat the bushes and did everything, and it all fizzled out. We got some money from Silver Cross, and we got some money from Vera Smith because of Dr. Gutierrez's relationship. And beyond that, a few donations from some board members and staff. You can go over and take a look at, in the community health center at the Giving Tree, you'll see who stepped up and donated something. But it all came down to, oh, you're from Will County government. I pay taxes to you. I donate money to the Red Cross and to the United Way and those people. I don't donate money to Will County. And finally, I just said, I'm not doing it anymore. I beat my head against that wall. That horse is dead. I'm not riding it anymore. And told the board we just eliminate the positions because it's going nowhere. We couldn't, you were on board then, you know that. And I think the hospitals gain from some of the services we provide. They have an incentive to do it, or find another way to provide that service. And that's just as good, because that's what they did at the jail. We said, we can't do this anymore, we're out of it. Well, they got probably better services than we had before. I don't want to say that. They got comparable.
Well, I would say they got as good services because they hired our staff.
They hired our staff. And that's, you know, that's a good model.
Yeah.
That's what you want to see from this board's perspective, is somebody else in the community coming in and doing what needs to be done. You don't have to do it all. In this case, we can't afford it, but I think we should bring it back to the board and analyze what's the cost, what are we going to ask them for, what's the utilization. If it's higher at Provena, 80%, 60%, whatever, it's only 10% up at Bolingbrook Hospital, well, we'll ask them for 10%.
But you have all that information. did it all, he gave it to us.
Right, but no, I understand that, but I mean, we just need to put it into a format that we can bring it back to the board and do it as a formal resolution,
Joe?
asking the hospital. Because, remember, we're gonna go to the county, and we're gonna ask the county for more money. And you know the first question they're probably gonna ask us, what have you done?
Right.
What have you done to try to find money outside of us? You're
Right.
coming to us, and we can say to them, look at here, we asked the hospitals. We cut a program and they picked it up at the jail. The
But they
jail,
can-
we asked the jail for money years ago, the courts, what'd they tell us, Joe?
Oh, you had no money.
Take a hike, they got no money. Well, now they got programs, probably cost them $500,000 a year.
But that gets back to the issue of what programs are you required to have? And if you got them here, and the ones that you've generously created over the years to meet the demand,
Right.
they're not required, so if you're gonna keep them, you gotta get some other funding.
That's exactly right. And those of us that have been in the business for a long time, and board members, and you all who are on the board, care about what we're doing. And we're trying to do everything to keep it going. And this is an example of what we're trying to do. Because go to the county, that's easy. Oh, you know, here, they're not gonna just hand you money. But if you can show them, we've done everything. We really tried, we asked the hospitals, we have done, beat the state up, and
And I guarantee you,
Joe?
if you're very successful in downsizing your programs and operating on this budget here, the state's gonna look at you and say, well, good program, okay. So your allotment goes from here down to here.
the state is a
And then you're
huge
gonna have to
problem.
fight to get some of these programs back.
I mean, the reason we're here is because of the state, let's face it.
Yeah,
It's not
absolutely.
because the county's given us $10 million. They could give us more, I'd love to have more. But the state of Illinois has brought us here on a July hot day when we were not even scheduled to meet. Because they're gonna stiff us for 65% on a dollar of what they owe us, hopefully. And going into the next year, there's no guarantee they're gonna pay us anything again.
Then can we propose a letter goes to the president of the board for Provena and Silver Cross? If it goes to the directors of the board, it gets attention.
But I would put in the letter
And I
that
would
you were
not
going
put a
to
date on there
eliminate.
in terms of terminating things yet.
It's the only thing people understand.
But that's not our mission statement. And we're talking about human beings here.
I need to interject.
No, we're not, we're talking about executives.
Okay.
At Provena well, when you get down to it, yes, I'm up here, I'm getting my X millions of dollars in salary and benefits and everything, and you're coming and saying, well, I want some money to help the people in mental health and everything. And they're going, oh yeah, well, we'll give it the consideration on our next board meeting. But I guarantee you, if you write and say, listen, we're under budget constraints, we're looking to eliminate this program, and we suggest that maybe you look for, for other methods, I guarantee you that will get their attention, and they will come to you.
Well, that would, I just didn't want us to put dates on, we're looking at eliminating programs by blank.
Well, you're
Well,
too nice.
I need to interject something here. Joe, the program that we're talking about as far as going to the hospitals and assessing, is that ACS?
Correct,
Okay.
ACS, yeah.
So that's the ACS program, okay? That is one of the programs.
What's ACS?
Capitated care. It's the program where the hospital calls us, we send somebody out
We
there.
basically handle the discharges, and they're either uninsured or Medicaid.
Right, I need to really paint the picture for you about where we're at. That's ACS program, okay? In May, we laid staff off in that program, okay? That program, no?
Oh, I'm sorry.
Yeah,
Go ahead.
that program is not in the budget next year that we drafted. We still have mashed a lot of different versions of this budget. That program is not in the budget next year, neither the revenue nor the expenses, and our budget is still off $1.7 million. You don't understand, it's way past all that.
So the hospitals are not availing themselves of this service now.
What we're doing is we're getting referrals from the hospitals. So when Silver Cross or St. Joe's has a patient, they discharge them to us.
But
So
you
there
can't
is
see-
some benefit, there's still.
Oh, it's standard practice.
No,
But you can't see them for a year.
Oh, no, we're talking about if we had to place our patients for psychiatric services. One agency told us they got about a year waiting list, another agency told us they've got about a 6-month waiting list, and this is for psychiatric services.
So these are people that appear at the hospital, they're determined they need psychiatric help, they're referred to an organization that can't see them for 6 months or a year. That's
Well, they come to us, and we try to see them sooner. And they bridge medications as best as they can.
But I'm just, I don't want to belabor this, but identify whatever it is those hospitals are benefiting from currently. And bring it back to the board in August as a recommendation that we send a letter to whoever we think would get the most action, asking them to participate. Because when Sue goes down to the county and asks for more levy, I know what they're going to say. What else have you done? We ask the hospitals, and it's going to make it, if you haven't done this, it's going to make it less likely the county's going to participate any higher level.
And I don't disagree with any of that, and certainly will do that, but my whole point is that program is $682,000. We're not gonna get $682,000. It's more than $682,000. We're not gonna get that from hospitals. And we'll try, but I doubt it.
But that 682 includes that program, but it's not exclusive of that.
No,
program,
that's
is
just
it?
that program.
Just that program?
And then you have to have an outpatient program here to see the patients. What are we gonna do? Just go to the hospital and say, okay, well, we don't have here, where are you gonna refer them? We won't have a program.
So then you send them a letter and you say that we're going to be ending the program and throw the ball in their court. Because then they have to do all the running around and getting the patient hooked up with somebody. That's their problem.
They got the patient in their emergency room.
Right.
That's their responsibility. They gotta do something.
And then just leave it there.
Right here. They have
Or Jim, or sitting on
They're
the
not
floor,
gonna do it.
stabilized,
Once they're
and
stable.
they gotta get in place.
That's right.
Which means if we don't take them, they can wind up sitting there for a long time. Or
Well, they can't
if they're
get them
stuck in the
out if
emergency
they
room.
don't have a referral source.
Right. But I guarantee you, they will create a referral source.
Well, maybe that would be us.
Well, all I'm
No,
saying
we
is,
can't do it. We can't
if we
afford
do
it.
this with the hospitals,
Yes.
we need way more than $682,000 to do this. We need a behavioral health program like we have now, which costs $2.6 million. It's one little piece of the whole division.
So
That's what it is.
what are you suggesting? Do we phase it out over 2 years or a
Well,
year?
I think the first thing we need to do is, the board needs to make, I need some guidance here, and let's look at these documents that are in your packet.
I still think you need a little PR, and you need a little lobbying, and you need a little community pressure. And you would do that by some articles in the papers, people talking about it, a little pressure on, instead of just always talking about it.
You guys are too gentle.
The first one,
You're too gentle.
the first one is, we'll talk about, since we're on behavioral health, is about, it starts with adult services program,
Years ago.
child and adolescent, PATH, it's behavioral health. Did that one? Yeah, you got it. Actually, they're all together. Mine are separate, but yours are all together. Yeah. So the first page is adult services, and we'll talk about that as long as we're on behavioral health. These are the programs that are in behavioral health in the budget next year. Adult services, number of employees, 15. Child and adolescent, 12. PATH, 1. Crisis, 2. Juvenile justice, 1. SAS, 13. River Valley, 4. Admin and general staff, total of 55 behavioral health staff. What the expenses are projected in fiscal 17, what the revenue is projected in fiscal 17, and then what the projected levy support is in fiscal 17. So if we want to continue behavioral health services as they are right now for next year, it's going to cost the health department $2,594,555. Okay? And mind you, we have a $1.7 million gap in our budget for next year that we have to discuss. And that's not including staff increases. Next page is.
Wait a second. The revenue projections, are those based on us having contracts with the state that they honor at 100%? They are. How much did we get this year from the state on those same contracts? We got nothing, right?
Mostly nothing.
Some of them.
Yeah.
So this, we could be looking at funding 5 million
Yeah.
as opposed to 2.5 million.
This is if we're whole. This is if they meet their obligation, which they haven't this year.
And you know, I really have a problem going forward and accepting any contract from the state of Illinois, whether it's DHS or public health, when they're planning to pay us 65 cents on a dollar for what we've already incurred with a signed contract. Why would we trust these people in any fashion?
And Jim, I think 50 cents on the dollar is the probability, and I think that's even too high in terms of reimbursement from what I'm hearing.
And they give you nothing for this. I think we need to have a discussion as to whether we want to enter into any contract with the state of Illinois until they make us whole.
What we budgeted for county fiscal year, Jim, on 17, it's less than $300,000. It's your juvenile justice, which is state. It's your crisis.
Can you come up
I'm so sorry.
Denise, we're talking money here. We need you up here.
You all know Denise Bergen? Denise Bergen, she's our financial coordinator. She's our numbers.
Right. What we budgeted for 17 for the state grants for DMH, it's just juvenile justice, which is about 80. It's crisis, which is about 127. We really reduced it down. We didn't include capitated care, even though we signed the contract. We didn't include it in the budget. So what you're at risk for is less than $300,000.
Okay, so the risk here
Right.
is not.
Right.
Okay.
I mean, on top of what the levy is already paying, you know, it's another $300,000.
What was the levy support anticipated to be for this fiscal year for mental health?
That's the other document that you have at your desk, the revised document that I was.
I'm just trying to get a sense of difference one year to the next.
Too many papers.
Just one.
No, all the way to the end over there. It's got revised at the top. This one, yeah. This one indicates let's see, I went back to the revenue and expenses from 2014, 2015, the proposed budget for 2016, the year-to-date as of 7/20, and then the revenue and expenses proposed for fiscal 17 as budgeted. So you can see down there where we're at. And then this is not a balanced budget, so this is just all proposed. We need to balance the budget, but as proposed, this is what we look like.
So if the state had paid us the money we anticipated coming into the fiscal year, we were subsidizing the board with levy, how much for behavioral health? This one, wasn't it 2.2 million?
Yes, 2.25.
Okay, so 2.25, we're up about $500,000.
So
Yeah.
your number on this for 17 hasn't been corrected yet?
Yeah. For
On your
health? Yeah.
No, for behavioral health. Your revenue is still too high for behavioral health. You have 3.4. We didn't back out the 682 on this that we did in the budget.
That's
So
right.
the 1.9 is not accurate.
Yeah.
It's the number that's on that sheet that you have.
So the revenue projections for
The revenue projection for
17.
behavioral health is 2.74.
Okay.
And the levy support required would be almost 2.6.
And these are secure. You're comfortable that,
Well, it includes less than $300,000 in state-funded grants, which we're at risk for.
okay, so those
Right.
300 here.
So it could be
would
2.9 million, right.
But-
And I want to add, those grants that we're at risk for, we're already being told they're considering moving it to what is referred to as fee-for-service. So I would say any state grant is, I really, quite honestly, I doubt if we'll see any money.
Ever?
For 2017, it's going away. I mean, the state is saying everybody's on Medicaid. So, like with the Mental Health Juvenile Justice, they're saying, well, keep the program, but you'll fund it by Medicaid billing.
So no reimbursement?
Reimbursement only for services provided, and we just cannot generate because of how it's structured. And by the way, the other thing with MHJJ, the services that we used to provide, they now have their own social worker. They also have their own staff. They're able to do that internally. And that's why I think they share. Our county fiscal year, we've only had 19 patients. And it averages about 2 hours a day of services.
Joe, I know that, and I don't have the numbers in front of me, but they're probably on one of these sheets. I know that in our fees for service reimbursables, we are way under what we anticipated coming into this year. And those have been adjusted in the 17 budget. Could you talk a little bit about why that's happening? Are we just not getting the patients in? Are we?
It's probably a combination of things. The good news is our item for managed care Medicaid, we're getting reimbursed there. We have DMH Medicaid, which we have not received reimbursement for. And that's the area that we're falling down in. Plus, we do see a number of people that, in my report, I'll give you the exact number, we see a number of people who have no resources at all. And let me shoot that number to you. We see 415 patients that are, we call it self-pay, but that's a euphemism because they're not employed, they have their job, and they're not able to get on any benefits package. But give you an idea, Medicaid, and it's a 2-year transition period. We're now seeing 2,070 patients who are under Medicaid, 52 under commercial insurance, 633 that are straight Medicaid, and that's a large number, but that's state DMH Medicaid, which they haven't been paying the bill for.
Well, why are they not paying the bill when they're paying other Medicaid providers? And a community health center is getting their money for medical services, and you're getting, Mary, aren't you getting your money for mental health services too?
Yes, absolutely.
Yeah.
Why is that?
And we're getting 3 times the rate that he is.
The FQHC is on expedited status, so it could be a fact that behavioral health is at the end of the line, the health department is at the end of the line, where where the FQHC is moved to the front of the line because they're on expedited status.
I know the expedited status, I remember that term.
Right.
Yeah.
But I thought
By
that
now,
these
we would have
court
got
orders
something.
that included all of Medicaid, but it doesn't apparently.
And they are paying the managed care organizations because they're able to hold costs down. And if they didn't pay the managed care organizations, they would pull the plug, and it would be disastrous. And I'll give you an example. Last week, we had a 2-hour meeting with Aetna Better Health. They love the services we provide. We're very responsive. And they tell us we're valued because, number one, we keep people out of the emergency rooms, which is expensive, and number two, we keep them out of the hospital.
Maybe they'd like to give us some more money.
Well, I'm just happy that they're paying us, and they pay us on a timely basis.
Yeah, but that's not a big piece of your money, is it? I mean, what's the total of your budget?
It's a growing piece. with 2,070 patients under managed care organizations.
And what are we anticipating for a year with those numbers? Is what you put in there.
Which ones are you talking about?
I'm talking about the managed care entities that
Yeah.
are,
Okay, so that would be,
that they're getting paid by the
Well,
managed
we
care.
included that, it's under DMH, it's under DMH and Medicare, or I'm sorry, MCO, 700,000 for clinical services. SAS also receives managed care payments, that's 750. And then physician services also.
That's
It could
pretty
be-
big number.
Exactly, I
Pretty
mean,
good.
you know, that's a
And they
combination
are-
of HFS and the managed cares, we don't break them out.
And the goal for the Collier counties, they're transitioning so that 100% of Medicaid in the Collier counties will all be under managed care. Now, Cook County is a whole different story, but the Collier counties, the goal is, last year was 50% under managed care. This year, it's 100% under managed care.
Okay, I guess we need to move on.
okay, so this is behavioral health,
Okay, so we need
almost 2.6.
2.6 and 300,000 at risk if we don't get a grant, so we're probably close to 2.9 levy.
Let me ask one last question
Yes.
about behavioral health. Since, Mary, you've got a division of behavioral health, at any time could the two of you, if it came down to it, combine your services?
Psychiatry, we could, but not Medicaid Rule 132 services, because they're on the encounter basis,
Yes.
which means they get paid for 20-minute sessions. Case management, the whole array of services that we perform are Medicaid Rule 132 services, which would include our counseling sessions, group therapy sessions. But like what Lake County did, and I brought this up over a year ago, Lake County Health Department has moved all adult psychiatry over to the FQHC. So if they get mental health services, they go to the mental health clinic, which is Rule 132 accredited, but they do all their psychiatry. In fact, I think they moved child and adolescent also. So all adult psychiatry, and in my board reports, the numbers are simple. It's almost 300% more reimbursement to see a advanced practice nurse in a psychiatrist.
If it's housed in one setting, the reimbursement rate would be higher and quicker.
300% higher.
Something to think about.
Well,
Something
we
to
have-
probably do more than think
No,
about,
we-
but to really outline
Mhm.
the feasibility and what steps would need to be taken to accomplish that, what it would mean financially and what it would mean for the patients. I mean, it looks like,
Yeah.
Well, we've talked about it and we have discussed it, and that means that in order for the FQHC to provide behavioral health services, they have to also provide medical services, primary care.
Okay.
The health center doesn't have a whole lot more room in their building to provide psychiatric and outpatient behavioral health. They
Okay.
just don't. They're squeezing in all over the place right now. If they were to provide and have the health department site as another site, because
Mhm.
even though we're across the parking lot, we're on the same campus, they have to add like an access point.
Right.
They have to provide primary care over here as
Right.
well.
Right.
You know how confusing
For the patient?
that is to the patient?
Yeah.
Do you know how disjointed that seems? Not to mention that we're kind of violating our cooperative operational agreement between the Board of Health and the Governing Council, which says that we will not have duplicative services. We're doing that now, and we have to address that.
well,
That's
we're
true.
already doing it, because we were doing mental health,
Right.
and now it's going on there. But, I mean, we can all agree that, so what?
We have space. We have, and I have a plan for how we can move people around and find enough offices.
Yes, to some extent, Mary, but you don't have enough services to cover what Joe's division is doing right now. There's just no
but
way.
I mean,
But
you know,
you
adult
know-
and child psychiatry.
Yeah.
Yeah.
Some
Yes.
counseling, we can take over some counseling. The rest of the
Yeah.
services, correct.
Yeah.
And I think
We
Lake
have to-
County is a model where all of psychiatry is performed at the FQHC, which also means they have to enroll in primary care, which is also essential for the chronically mentally ill individual.
Well, and it's good for the community health center,
Yeah.
because then now
Yeah.
they have another patient.
Well, plus you've got the psychiatric component under a medical director
Yeah.
versus, I don't think we used to have medical director.
We
Here
don't.
have
Yeah,
it.
we don't.
I think that,
It would be
It sounds-
a win-win in our,
Yeah.
in my opinion, I've done these programs before and merged programs. We have an already existing integrative model. We have primary care providers who bridge medications, who see patients. Many of the patients or many of the patient types that Dr. Triani has broken down for us are patients we already see in our primary care practice. The severely mentally ill patients are seen cooperatively by both the psychiatrist and us. So they'll see the psychiatrist and us twice. And we do a combination of things as an integrative model. We have, respectfully, we have physical space to house at least 4 more therapists. We have a behavioral health suite. We're going to have 2.5 FTE of psychiatry time. I see it as a win-win. It would be, as Sue was saying, mutually, it would get our numbers up. It allows us to be self-sustaining and continue to do that and still be a rock in this community as far as primary care.
How do we choose the patient? How do we choose who's seen and who folds in at the health center as opposed to not being seen? How's that distinction made?
Well, we get what I refer to as hospital discharges. We get
Well, we
into
have
the,
existing patients,
yeah.
and
yeah.
some of the hospital discharges are new patients. Some are existing patients, I would imagine.
Yeah.
So we don't have the capacity at the health center to ramp up and do, basically, bring behavioral health over to the health center. So
Yeah.
how do we decide who's seen?
When you say the capacity, just let me make sure we're on the same page. You mean that we don't have the capacity in our schedules to accommodate the numbers?
Exactly. That's
And
what
and
I'm
let me,
saying.
I've got the numbers here. Currently, for adults, 801 of our patients are seeing a psychiatrist and a psychiatric nurse. For our child and adolescent program, 721 patients are seeing the psychiatrist and the psychiatric nurse. So that's a pretty healthy volume, but think of it this way, our reimbursement is probably 1/3 of what we would be getting versus if they were being seen over there.
So do we look at what your capacity would be, like your maximum capacity, and then determine that number, and then transition the remainder to
My-
other
yeah.
services? And who
But,
makes
yeah,
that decision?
my recommendation has been, following the Lake County model, move all of psychiatry, that's our move all of our psychiatry out of the community mental health center and put it in the FQHC. And that we're looking at, was it 1,400 patients, 1,500 patients? And of course, with this is a significant increase in reimbursement rate, and it's, I think that alone will keep you guys really busy, and then we could continue doing the traditional community mental health.
I would suggest.
That's a great compromise.
Yeah, well, and not to cut you off, but in speaking to your points too, because I know that's a concern of yours, transition, it's tempestuous and it's painful, but we did it on a very micro scale with the injection clinic, and it took a couple of meetings, and they said, here's our registry of patients, here's the people you need to see tomorrow, and here's when the next appointments are, here's when their next appointment should be. And so it's a detailed conversation, a very granular conversation about each patient. And we can do that because we know the patient. And then we just decide this patient has to be seen soon. If this patient has to be seen soon and the psychiatrist is booked out a month, then they need to see a primary care provider for 3 months or 2 months until they get to psych. And so it's a very specific and detailed, granular conversation about each individual patient. And we case manage. It's basically case management. They're case management discussions. Here are their diagnoses. Here are their risks. Here's when they need to be seen. Here's when their medicine's going to. run out, and we fold them into the health center in that way.
No, I was actually speaking about transition to the rest of the clients that you won't have the capacity to see. Because unless I'm misunderstanding, we're talking about transitioning behavioral health services.
No.
Not all of it.
Not all of it.
No.
No.
Psychiatry.
Psychiatry.
Just
We're not going to
psychiatry.
be able to afford to sustain the rest of the behavioral health programs. Psychiatry is not
And
just.
that's where my recommendation would be, zero-based budgeting. Let's transfer psychiatry, then let's look at what dollars we have available and size the program to meet the dollars that are available.
Our psychiatry costs in the budget right now are what, $380,000?
And then, of course, we have 2 psychiatric nurses. That goes along with that. But I think we need to look at the other programs. And in my report, I made some recommendations for program eliminations, and that it also might include downsizing the traditional outpatient services. I mean, ideally, continue outpatient adult, outpatient child and adolescent, maybe adult on a smaller scale, but with zero-based budgeting, here's a dollar we have to work with, and we'll build a program and have a certain capacity, and when we hit that capacity, we don't move until additional dollars come
I
in.
would rather go to the county board looking for more money,
Yeah.
having this model change. What Joe was talking about is zero-based budgeting, transferring psychiatric over, whatever that means. And I don't think we want to get into the details of what that means. You all need to work on those details. But I'd rather go to the county and say, look what we did. We cut our costs by $750,000, and our reimbursement is going to go up by $400,000, but we still need a little bit to keep this piece that he needs, that he's going to rework.
And Joe, I was going to say, we've already done that. We decided to close down our pharmacy in the clinic. That's happened.
Yeah, I know.
And Dr. Vawaz is here. And what happened to all our injectables?
Thankfully, Mary Maragos and Dr. Berg were very involved in that transition process. All of the patients, along with the outgoing nurses that were subject to the layoff, they worked very hard to make sure they transitioned all of those injection clients over to the care of the community health center. And those were the most difficult, I would say, patients to transition because of their care and their needs were much greater than the care of our traditional psychiatric patients who receive oral medications.
So we've taken your 26 highest risk patients, including your 5 Clozaril patients, by the way,
Yes.
that aren't injectable. And Clozaril is tricky.
Yeah.
You have to be registered for it. You have to, only 2 people
Yeah.
can, only the psychiatrist. So it has gone, I think, very smoothly.
Yeah.
It's actually, it gets the job done for the community. It meets the service need. It's a nurse-run clinic that I oversee. We get a tick mark for an encounter, and that helps us. And as soon as they get to see the psychiatrist, well, when they see the psychiatrist, then we get that enhanced rate. And that's just with 26 patients. Imagine with 1,500 patients, what our revenue would be if it's 300%.
And the benefit to the patient is not only are they getting the psychiatric need, now they're getting referred in the community health center, which could be 3 or 4 visits depending on the
Because your diabetes is never going to be controlled if
Yeah.
you're seeing things. And when we control you seeing things, and your diabetes, you have a sugar of 400, then you're hitting the emergency room.
Yeah, the vision of this thing we're sitting in, what was the community health center, was that it would be an asset and a referral source for family health services, for mental health, for all of the health department to fill this gap of there's no place to get care. They go to the emergency room, medical home. You know, the benefit isn't just the psychiatric visit. Benefit for the patient and for you all is that your encounters go up. Because if we can increase the number of encounters significantly, now we drive down the cost per encounter, which are approaching $200 per visit.
Yeah.
So, you know, you add 2,000-3,000 visits, and, you know, maybe that comes down to 190 or something, right, Denise?
Well,
I think
it's great.
I think you need to get together and you need to put this model on a piece of paper and bring it to the board. You can do it by August.
Part of it's already in place.
Well,
Part of it is in place.
I need to interject, and I'd like us, I don't want to leave here without going over
No,
the
I know.
health center and their programs,
Right,
because
we need to do that.
the health center, you know, I just have to say, I feel like we're losing the focus here a little bit. The point is not to live paycheck to paycheck again. The point is not to just balance our budget again and only cut 7 people this time. And then next year, you know, budget our, you know, we have to make some big changes. We have to make some theoretical, we have to make some programmatic changes. This nickel and diamond, and, you know, we'll work on this model, and I think it can work, and I think it's gonna be good for the agency. But I will tell you that I don't feel comfortable coming back to the board saying, okay, well, we're gonna, you know, transition X over to the health center, and we're gonna just cut, you know, X, Y, and Z in behavioral health, and okay, now we're balanced the budget. But then next year, we're back here again doing the same thing. And in the meantime, when our expenses are going up and our wages are going up, we're gonna have a deficit, and we're gonna come back with a budget reduction plan. We have to get out of that, we have to get out of that wheel. It's not healthy, it's not good for the agency. I think we have to make a decision, what do we wanna do? As a board, what do you wanna do? Do you wanna be in the behavioral health business, or do you wanna be in the health center business?
Well, I'm not sure that we're ready to make that decision or recommendation at this point. I think we need to take a look at what Joe has proposed here, which is zero-based budgeting, with transitioning. I mean, it would be, the easiest thing to say would be, well, we're gonna be out of behavioral health come December 1, and we're gonna shut the health center down, and we got all this extra levy money, and we're gonna be this. What about the patients?
That's more,
Well, no.
that to
What
me,
about the
There
patients?
has
and
to
it's
be
not
a-
as much about the agency, I heard what you said. It's about the patients. Where on earth will they go if we don't try something to try to keep them in the system and give the state of Illinois to try to correct itself and work something else out? My objective is for us to try to keep Will County Health Department viable for the patients that desperately needs this place. And I understand what you're saying. But right now, it's like we need to give the state of Illinois a chance to correct itself before we eliminate anything.
Well, I think that, you know, I don't disagree. I don't. And I know the patients are important to me as well. But it's difficult to sustain an agency. It's difficult to keep staff when this continually happens. We lost 3 individuals in the past few weeks solely because they want stable employment. We've lost managers because we haven't given increases to managers, and because they are the ones that have to pick up all of this stuff after the bumping and retrain the staff and pick up all that mess and deal with it. We're losing managers. This is, you know, this is what we need to do. I understand that, but I just hope the board understands from our perspective that we need to get out of this spiral. It
Yeah.
feels like a spiral.
You know, there are 2 big factors here we have no control over. One is the state of Illinois, the other is the county board. And if behavioral health and the health center disappeared tomorrow, and you had $5 million of extra levy, do you think, what are the odds that the county board's gonna let you keep that $5 million?
No, not very good.
Not very good, no,
Right.
because they're trying to pay off bonds. So if everything disappeared and you had that levy, and you went down to build your budget, and you told the county, it's probably $4 million here that we don't need because these programs are gone, but we would like to do this with it. Boy, you'd be lucky to keep 20% of that.
Unless they tell us to keep it for our building.
Well, they could do that, or they could use it to pay bonds, but we can't assume that going away solves our problem and makes us fiscally sound going forward. That's a big risk, and the risk is with the patients losing services and the jail becoming the mental health and the emergency room becoming what the community health center is taking care of. Now, a year from now, 2 years from now, 5 years from now, what's it going to look like? We've got other providers here, and what are they going to look like? Can they handle the capacity? I don't know. But for right now, and I think Billy is summing it up well, that we need to take a look at what other way can we do this, short of just saying, we're not doing it anymore.
That's pretty much.
Judy, how do you feel about it?
I think so. I think we first need to look, though, at what we absolutely have to do. Like, do we have to do that vision screening? Do we still do it? Stuff like that. We don't have to do some things. And then...
And I tell you what, there's one other piece to this, and Abby, I'm going to pick on WIC, okay? Our WIC grant is how much? Million?
1.4, I believe.
1.4 million. What are the costs of the WIC program?
A little bit higher.
A little bit. What's
Yeah.
a little bit? 2.1?
No, I think that there's like 3 months that the county funds completely.
3 months.
So it pays for 9 months, and we pay for 3.
Okay.
Yeah.
So we're paying
Covers
for...
covers about 75% of
We're
your
paying for
costs.
about 400 and some thousand? Okay. The other option is to say, we're not going to pay 400,000 for WIC. Whatever the grant pays for, that's what is going to be our WIC program. And we free up that 400,000. And if we can't do it, maybe we don't do WIC anymore. Maybe we don't do vision and hearing. We just raise the rates for vision and hearing, which is going to make it almost balanced.
Should pay for itself.
But I think that grants never pay everything. And where the grants are lacking, you go back and you say, we're going to live with what we get, whatever that means. However many services we can provide, we're going to take that levy and we're going to do something else with it. Maybe we're going to keep behavioral health, some of it. I don't know. But in times of crisis like this, you got to look at everything. I wrote a note for myself as we were talking about EBO, after we were talking EBO. I said, what about NBO? We got a huge office up there. With the changes we've made and the reductions we've made, do we need to go back to the owner? Drury Rhodes, I know who the owner is. I negotiated the thing, I rented the space. Do we need to go back and say, I'm sorry, there's a third of your space we don't need anymore, and save however much money? You have to look at everything and from the perspective of, do we really need to do that? And we're focusing kind of on Joe here and on the health center, but you got WIC.
But it sounds like you're scrambling to save nickels and dimes when your debt is hundreds of dollars. I mean, look, people, the iceberg is here, and we're not even heading for the lifeboats. We're just still kind of talking about, oh, look at that, that's terrible.
Well,
because it's going to be driven by the state. I mean, a year from now, we probably won't be sitting here because there won't be any money and nobody will be working here. And you talk about the patients will go back to what they did years ago.
To the emergency room.
To the emergency room.
And jails.
And jails, yes. I mean, that's the reality. If the state doesn't pay what you're supposed to be doing, then you can't provide the service. And you can't provide the service, then the results are that.
And that's the role of the board, is to determine what are the priorities. First of all, what are the core programs we have to do? We know what those are. That's environmental health and disease control. That's all we have to do by records.
Then get rid of the rest. I know. But that's reality. You gotta deal with reality, not
It's not today's
fantasy.
reality.
Well, no.
It may be a reality in a month, in
Yeah,
2
6
years.
months, yeah.
But I
Not
don't
2
think
years,
we're
6
there.
months.
I think there's a way to look at the resource, where the resources are going, and reshuffle some of that, and cut some expenses, ask the county for more money, ask the hospitals for more money, and try to live, take a look at whether you can live with the money they give you. This is what you're giving us, and this is what we can provide for those services.
Then do it.
If we can't do it, then a community-based agency may come in and pick it up. And again, we're getting back to the core problem, cost of doing business. How much do we pay for a counselor versus what Trinity pays? That's why our unit costs are so high.
It's a benefit package.
Yeah. You know, probably,
Which is out of our control,
Yeah.
as a board.
Yeah.
and we don't, yeah, we have no input into that. The county board passes, they negotiate along with the county executive, they approve the wage package, and we got paid. And that's where we're not getting levy growth to pay for those wage packages. That would go a long way. I mean, we've lived with the same levy for how many years now?
It's gone up and down, you know, a few hundred, couple 100,000 here and there, but it's been about 6 years.
Yeah, same levy. What have our costs done in 6 years? That's where a big part of this. That's why when you have a WIC program here versus a WIC program in a community-based agency, they can maybe do it for the grant. We can't. Costs are too high.
But we also in WIC have some of the highest paid employees. I mean, everybody that's in WIC has been here 20 years, 30 years.
Yeah.
And you have those high salaries. I mean, and we cut to the, you know, when we had WIC and case management together, we had 4 managers over there. So when we split off family case management, we kept 2 managers. We are seeing how difficult that is with just a couple managers over there, because you still have 7,500 funds. And, you know, and the nearest, there's no other WIC agency in the county, and the closest WIC agency is 26 miles away. So, I mean, that's in another county. So that's one of the reasons WIC is as high, you know,